All right, good morning, everybody. We're going to get started today. I'm Tom Clennell. I'm one of the chairs for this conference.
And I'm Selena DeBoer. I'm also course chair for this conference. Good morning.
And so along with Dr. Rhonda Watkins, who sends her regards as she's out on leave today, welcome to day 2. For some of you, day 1. Today we'll be covering pediatric sports medicine topics, and we'll have presentations from our multidisciplinary specialists in the fields of pediatric orthopedic surgery, sports rehabilitation, and sports medicine. And we will also have multidisciplinary workshops today to learn about weight training in young athletes, as well as concussion vision evaluation and rehabilitation. Some general housekeeping notes for today. So please, if you can silence your phones, that would be spectacular. We have access only to the library hallway and then the 2 side courtyards right here. So please try and maintain your space in those areas. And then you'll be receiving an email today with speaker surveys via Qualtrics if this is day 1 for you. If this is day 2, you received that yesterday. Please fill those out. It will help us tremendously. And then you'll also be receiving an email on the last day of the course, which is today, from Qualtrics as well, with a personalized link to complete your online course evaluation. You will not receive CMEs or CEUs without completing that, and you have 30 days to do so. If you don't, we will have difficulty giving you your CEU credits. And then most importantly, we would like to thank our exhibitor sponsors, as this would not be possible to be such a good conference without them. So we have Vald, Siemens Healthcare, Kiowa Chiron, Enovis, and Alexian. Please make sure you take the time to go speak with them and find out about their products as well today. We're very thankful to have them. And so with that, we will go into our first presentation. So I'd like to introduce Dr. Michael Chau. He will be presenting on hip injuries in young athletes. He's an orthopedic surgeon who specializes in the surgical and non-surgical management of sports-related injuries and conditions affecting the shoulder, elbow, hip, and knee in young athletes. He graduated from Northwestern University with a bachelor's and master's degrees in biomedical engineering. He received his doctorate in medical sciences, focusing on cartilage biology from Karolinska Institute in Stockholm, Sweden. He earned his medical degree from Penn State College of Medicine and completed his residency in orthopedic surgery at University of Minnesota. He completed a pediatric surgery fellowship at the University of Texas Southwestern at the Scottish Rite for Children, followed by a second fellowship in orthopedic sports medicine surgery at Cedars-Sinai at the Kerlan-Jobe Institute. He has served as a team physician for Pepperdine University and has also served as an assistant team physician involved with medical and surgical care for the Los Angeles Dodgers, the Los Angeles Rams, and the Los Angeles Galaxy.
All right. Welcome, Dr. Chau. Just hold the mic for audio.
Okay.
Thanks.
Right. Thank you for that. Welcome. Good morning. Thanks for this opportunity. I'm Michael Chau, one of the new faculty members at the Pediatric Orthopaedic Department, and I'm excited to talk to you all this morning about hip injuries in young athletes. I have no conflicts of interest for this presentation, except to disclose that I am a surgeon. I enjoy operating and I get paid to operate. With that said, I wholeheartedly believe in pursuing the most conservative treatment to meet the patient's goals and provide best long-term outcomes. So in the next 30 minutes or so, I'll go over a brief review of hip anatomy and growth in children and adolescents, discuss several common hip injuries in young athletes, and propose a stepwise approach for managing hip injuries in the primary care setting. To start with a basic definition, the hip is a weight-bearing ball and socket joint. In a normal hip, the femoral head receives about 170 degrees of a hemispheric coverage from the acetabulum, which together with the labrum provides a level weight-bearing surface that is parallel to the ground for walking and running. Just like trying to balance any object on a sphere or a ball, hip biomechanics is optimal when there is a horizontal platform for the body to distribute axial forces evenly. The hip, being one of the most mobile joints of the body, needs to be contained in order to function properly. The static stabilizers of the hip include the labrum, that behaves like a suction seal, ligamentum teres, that acts as a check rein, and the capsule, with the iliofemoral ligament being the strongest ligament in the body. There are 21 muscles that span the hip and allow 3 degrees of freedom. These muscles also dynamically stabilize the hip, which explains why physical therapy is often an effective first-line treatment for hip conditions to improve hip stability and hip biomechanics. As we all know, the skeleton of children, as compared to adults, is unique for having cartilaginous growth centers, and there are multiple of these physes and apophyses around the hip. Growth cartilage is one of the weakest structures in joints, and many times it is the first structure to fail during injury, particularly through the most brittle layer, which is the calcified layer, where cartilage remodels into bone, and this layer is called the zone of provisional ossification. In normal hip development, the femoral head is closely related to the acetabulum and ultimately results in a congruent joint. When this relationship is lost, however, such as with femoral head subluxation, dislocation, or growth arrest of the triradiate cartilage, acetabular deformities can result where the acetabulum becomes either shallow or incongruent. So in a way, hip development is like jelly or jello, where the femoral head and acetabulum influence one another to develop similar contours. Sorry, there's a Zoom meeting pop up here. One second. All right. Clinically, there's a spectrum of proximal femoral development that, in general, can be influenced by conditions such as trauma, repetitive stress, or impaired blood supply that injures the cartilaginous growth centers, which results in abnormal relationships between the femoral head, neck, and shaft, where their shapes and dimensions can be distorted. The neck shaft angle can be increased, such as in coxa valga, or decreased, such as in coxa vera. Or the head-neck offset can decrease, causing impingement, or this can result by slippage of the epiphysis. Similarly, there is a clinical spectrum of acetabular development that ranges from undercoverage in a borderline or dysplastic hip, to abnormal coverage in acetabular retroversion, to overcoverage in conditions called coxa profunda, where the socket is deep, or acetabular protrusio, where the femoral head protrudes into the pelvis. There are numerous potential pain generators in the young athletic hip. A comprehensive approach to hip pain would be to know the anatomy 360 degrees around the hip, or in layers, including the major anatomic structures such as the bone, cartilage, muscle, tendon, ligament, bursa, as well as nerves. Of course, then there are the diagnoses that should not be missed because of devastating sequelae, if they occur, such as infection, tumor, and avascular necrosis. Alternatively, a simplified approach to think about hip pain is with 3 diagnostic categories, which are trauma, developmental, and other, and we'll cover some of these diagnoses shortly. This slide shows some of the sports that require the hips to be positioned at extreme ranges of motion, such as water polo and ballet, or require the hips to function under repetitive stress, such as soccer, football, ice hockey, track, which can either result in direct injury to the hip or cause pathologic changes of the hip that in turn increase the risk of injury. Now let's talk about some of the common hip injuries in young athletes. In skeletally immature young athletes, apophysitis and apophyseal avulsion injuries are more common than conditions like tendinitis and strains because of the more vulnerable growth cartilage. So apophysitis, apophyseal avulsion injuries are defined by inflammation or traumatic separation of the apophysis caused by overuse or sudden forceful eccentric contracture. These are similar to conditions we know in the knee and in the ankle, such as Osgood-Schlatter, Sinding-Larsen-Johansson, and Seaver's apophysitis. Diagnosis is based on history. These patients typically present with insidious onset. Sometimes they have severe pain with popping. And then x-rays include standard AP lateral x-rays of the hip, and MRIs can be obtained if the diagnosis is equivocal. Treatment is usually rest, ice, NSAIDs, physical therapy for stretching, strengthening, and then a progressive return to sports. These conditions are typically self-limited, but can persist for up to 18 months and sometimes until the growth plates fuse. So here are some examples of some patients of mine. Although apophyseal avulsions such as ASIS, AIIS, and lesser trochanter can be significantly displaced, most of these will actually heal, remodel, and become asymptomatic. Apophysitis can be subtle, and therefore contralateral radiographs are helpful for diagnosis and sometimes an MRI, which will show increased T2 signal, but usually not needed most of the time. Surgery is rarely indicated in cases of significant displacement or if there is a symptomatic malunion or non-union. Slip capitofemoral epiphysis, or SCFE, is a very important condition to recognize and diagnose because of its negative long-term implications if left untreated. It's defined as displacement of the femoral neck relative to the femoral head through the growth plate, and it should be distinguished from a femoral neck fracture because it behaves differently. It's characterized by antecedent epiphyseal lysis, or widening of the growth plate, slow displacement, and intact periosteum or perichondrium. The result of SCFE can be loss of motion, premature osteoarthritis, and physical disability. SCFEs can be categorized as typical if they occur in adolescents during their peak growth velocity between the ages of 10 and 15. The typical risk factors are obesity and male sex. The atypia of SCFE include endocrine disorders like hypothyroidism, growth hormone deficiency, panhypopituitarism, renal dysfunction, and prior radiation therapy. SCFEs can also be classified based on their chronicity as acute, chronic, or acute on chronic. Severity based on the Southwick angle as mild, moderate, or severe, and instability as either stable or unstable based on their ability to mobilize with or without assistive devices. On physical exam, patients typically have a painful antalgic gait or Trendelenburg lurch. They can present with external foot progression angle. Their hip range of motion is typically limited and painful. Obligate external rotation with hip flexion is pretty specific for SCFE. And here's a video, if you would play, showing how obligate external rotation occurs. And that is with flexion, the metaphyseal bump or that post-SCFE deformity hits the rim of the acetabulum and then follows the shape of the rim, which drives the hip into external rotation as the bump follows the rim posteriorly. Imaging for SCFEs are AP and frog-leg laterals. However, if the SCFE is unstable, then it's more reasonable to get a cross-table lateral so that we don't iatrogenically cause further displacement of the femoral head. Things we look for qualitatively are Klein's line, which is a line drawn on the superior aspect of the neck, which normally would intersect the epiphysis. We look for subtle physeal widening, decreased epiphyseal height, metaphyseal blanching, which is indicating superimposition of the head and neck, and then lucency around what's called the epiphyseal tubercle, which indicates the rotational component to SCFE. Treatment goals are to prevent further slipping, minimize avascular necrosis, avoid the post-SCFE deformity, which would cause femoral acetabulum impingement, and prevent early onset osteoarthritis. For stable slips, the standard of care is in situ fixation. For unstable slips, the treatment is more controversial. Standard of care would be percutaneous screw fixation with any incidental reduction from positioning on the operating table. And then closed versus open reduction is more controversial. Same with proximal femoral primary osteotomy and or reduction of the hip called the Dunn procedure. It's important in the primary care setting to know that SCFE can occur bilaterally, either at the same time or over 50% within the first 18 months. So if the contralateral side is not fixed, the patient should be warned of the symptoms of SCFE, which are hip pain, groin pain, thigh, and or knee, because of referred pain from the obturator nerve. Once a diagnosis of SCFE is made, the child should be immediately made non-weight bearing, restricted to crutches or wheelchair, and referred to an orthopedic surgeon. So here are a couple cases of my patients. This is an 11-year-old male, chronic mild stable SCFE, underwent in situ screw fixation. And this is a 12-year-old male, acute on chronic, severe unstable SCFE after a fall while playing basketball. He underwent incidental reduction and percutaneous screw fixation. Return to activities and sports in my practice is usually 3 to 6 months, depending on the stability of the slip. But ideally, after the capital physis has fused or closed. Next is femoral acetabular impingement, which is another condition most commonly seen in young athletes. It's defined as hip pain and dysfunction due to structural mismatch between the femoral head-neck junction and acetabular rim, and this can lead to labral and articular cartilage injury. The etiology is not always known. It's thought that it could be a sequelae from trauma or childhood conditions such as skiffy, like we just talked about, developmental dysplasia of the hip, and Perthes disease. It can also be caused by adaptive changes during the growing phase of the hip with increased sports participation and high intensity at a younger age, as is with the trend these days with pediatric sports. The natural history was initially hypothesized to cause idiopathic osteoarthritis in young patients without hip dysplasia. And this was proposed by Dr. Guns in 2003. And then based on subsequent multiple longitudinal studies, the evidence is fairly convincing that CAM-type femoral acetabular impingement predisposes to hip OA in certain patients. However, the association between the pincer-type FAI and osteoarthritis remains somewhat unclear. FAI is a clinical diagnosis because some people with radiographic findings of FAI do not have any clinical symptoms. So the current definition of femoral acetabular impingement is a triad of symptoms, clinical signs, and imaging findings. Initial treatment usually consists of rest, activity modification, NSAIDs, and physical therapy. Although FAI is an anatomical, bony problem, the rationale for physical therapy is that it treats any compensatory muscle injury of the rectus, psoas, adductor, or abductors. Operative treatment for FAI conventionally is hip arthroscopy with labral repair, osteoplasty, and cartilage restoration, and there are various indications as well as contraindications. So these are videos showing a CAM-type FAI impingement before and after arthroscopic femoroplasty. You can see that on the left with hip flexion and internal rotation, the CAM deformity abuts the acetabulum and creates what's called a vacuum effect, which is a sign that the labral suction has been violated. After CAM resection, there's no longer impingement and the labral suction seal is maintained, even with increased range of motion. Outcomes and return to sports after FAI are generally good, with significant improvement in patient-reported outcomes and up to 70 to 84% returning to sports at the same level or higher. The next condition is adolescent hip dysplasia, defined as the acetabulum being too shallow to support and cover the femoral head. This may be a result of subclinical development of DDH from childhood that is asymptomatic until the child grows and becomes more active. It's a rare condition. Some of the risk factors are female firstborn, breech, family history. Symptoms are usually pain within the groin area, but can be relatively nonspecific. We know based on natural history studies that there is an association between hip dysplasia and early osteoarthritis. This idea that pressure is force over area when there is less area for the femoral head to contact the femur, it edge loads and can cause cartilage injury and subsequent osteoarthritis. Treatment goals of hip dysplasia are to relieve pain, restore function, and prevent the onset of osteoarthritis and preserve the hip joint. Non-operative management includes observation, lifestyle modification, PT, NSAIDs, or injection. Operative indications are when non-operative management fails, and the treatment conventionally is the periacetabular osteotomy, which is a reorienting osteotomy. You cut the acetabulum, reorient it so that the acetabulum covers the femoral head more evenly. This can be coupled with a hip arthroscopy if there is labral repair and or osteoplasty if there is a CAM type or a pincer type FAI lesion. So this is an example of an 18-year-old female dancer that I encountered during my training. She had combined adolescent hip dysplasia and cam-type deformity, and she underwent a combined hip arthroscopy followed by periacetabular osteotomy, images you see there, and she had been doing well 1 year later. So does PAO change the course of natural history of hip dysplasia? Current literature seems cautiously optimistic. However, if you look at the studies, the survivorship of the procedure falls pretty precipitously each and every decade. The earliest study done by the Swiss surgeons showed about 30% survival rate at 30 years follow-up. So patients typically get this surgery done around 29. By the age 60, at least you can push the need for a total hip replacement as late as possible. Several smaller series in the literature suggest promising results for return to sport, rates between 80 to 93% for patients undergoing PAO, as well as combined hip scope and PAO. So that is promising for our patients. Femoral neck stress fractures. Diagnosing this injury can require a high index of suspicion because patients sometimes don't have severe pain and they can continue to ambulate. So careful history and physical exam is important. Imaging with X-ray may not be sufficient, so either a CT or an MRI can show the edema within the femoral neck. Femoral neck stress fractures are classified as either a compression type if they occur in the inferior aspect of the neck, and these can be treated non-operatively, versus tension type where the fracture occurs on the superior neck, and these are most of the time treated with operative management. So these are two examples of femoral neck stress fractures that require surgery. The one on the left is a compression-sided stress fracture that creeps up to about 50% of the width of the neck. And the patient on the right has a tension-sided femoral neck stress fracture, and these are treated with cannulated screws. And then hip dislocation is very rare, most of the time due to high energy trauma, either from contact sports or motor vehicle accidents. Most of these are posterior, but they can be anterior. Treatment is urgent, closed versus arthroscopic assisted versus open reduction within 6 hours. It's thought that the longer you wait, the more risk you have for a vascular necrosis. After reduction, it's important to get a X-ray or CT or MRI to make sure that the reduction is concentric and there's no interposed fracture pieces. And if there's not, then the treatment is protected hip motion and weight bearing for 6 to 12 weeks, and then gradual progression to activities thereafter. The most dreaded complication after a hip dislocation is AVN. And it can occur anywhere between as early as 3 months to as late as 2 years. So after reducing a hip, we should follow these patients for at least 2 years, if not longer. These are two patients of mine, not sports, but motor vehicle accidents. The one on the left has an anterior central hip dislocation, whereas the patient on the right has a posterior dislocation. After reduction, CT demonstrated that the reduction was concentric, and even the fracture, the femoral head neck fracture for the patient on the right was anatomically reduced. So these two patients are doing well with just protected weight bearing and no surgery indicated at this time. The prognosis of hip dislocation is not well known due to the paucity of the injury. However, a recent systematic review of 27 articles comprised of 145 patients found a low rate of recurrence at 3%, and optimistic outcomes of 80% of patients having no pain, 87% returning to sports at their final follow-up. However, 11% showed radiographic evidence of AVN. In the primary care setting, I think hip injuries can be approached in a stepwise fashion with a focused history, physical exam, appropriate imaging, and the final decision to either treat or to refer. A good focused history may in and of itself lead to the correct diagnosis. So in the setting of known sports trauma, useful questions include the mechanism of injury, example, contact versus non-contact, position of the leg when the injury occurred, the presence of a pop or bruising, location of the pain. I often ask my patients to place one finger on the point of maximum tenderness, any mechanical symptoms, sense of instability, and whether or not they can weight bear with or without crutches. Developmental conditions can be more vague, and the lines of questioning can include perinatal history. Again, location of the pain is important, and relief and exacerbation factors. Other conditions that cause hip pain may require more thinking outside the box. For instance, asking about signs and symptoms as well as family history that relate to AVN, infection, inflammatory joint disease, and tumor. In the 15-minute visit, the physical exam should take about 3 minutes. This table is just an example of what I do. It is important to rule out referred pain from the lumbar spine, such as with a straight leg raise to test for lumbar radiculopathy. The hip exam can be broken down, simplified into 3 parts: inspection, palpation, range of motion, neurovascular, and provocative. In general, it progresses from least to most painful or provocative, but from a practical standpoint, it should flow readily from one part to the next. One of the most sensitive findings on clinical exam has been shown to be groin pain and a positive anterior impingement test, which is performed by positioning the hip in flexion, adduction, and internal rotation. With hip impingement, patients typically also have decreased range of motion in flexion and internal rotation. In terms of radiographs, the views depend on what diagnosis you are evaluating for. So for example, for hip impingement and dysplasia, 3 views are typically sufficient, which are the AP pelvis, the 45-degree Dunn lateral, and the false profile. Conventionally, there are several quantitative radiographic measurements for cam and pincer impingement, as well as for hip dysplasia. I included these parameters and measurements on the slide for reference. There are also several qualitative radiographic signs that are commonly used, and shown here are the subtypes of pincer impingement, which can be further classified as focal or global. And similarly, the drawings on this slide are meant for reference purposes. The tonus classification shown here is commonly used to grade hip arthritis. It is useful to note that grade 2 is the start of subchondral cyst formation, and this is past which hip arthroscopy is usually contraindicated. Advanced imaging can include MRI and CT based on what you are looking for specifically. MRI is good for looking for labral tears and also differentiating between a tear and a benign variant, whereas CT is useful for surgical planning, as it can tell you where the cam and pincer lesions are. In terms of further diagnostic testing, this was a study recently performed by our group looking at the outcomes of intra-articular cortisone injection in adolescents with hip pain. It was found that corticosteroid injections is a useful diagnostic tool and can actually provide prolonged improvement in patients with intra-articular hip pain due to a labral tear, but these patients did not have FAI. On the other hand, it was found that corticosteroid was only limited in its efficacy when treating patients with bony FAI lesions, most of whom required surgery. So at the end of a primary care visit, I think the decision to treat or refer comes down to whether the condition is self-limited versus conditions that can worsen and even cause irreversible articular cartilage damage over time. In general, I think it's reasonable to have a low threshold for referral, particularly if there is uncertainty with diagnosis or treatment, in order to provide the best optimal care for our patients. So in summary, hip injuries in young athletes may not only stop kids from participating in sports, but may also lead to premature osteoarthritis. Early diagnosis and treatment is critical to prevent the irreversible articular cartilage changes. While there are a lot of pathologies that can inflict the young athletic hip, I think an accurate diagnosis can be made following a structured workup. Common diagnoses are common, but we have to remember the uncommon ones because they can result in devastating sequelae. Non-operative management can be the definitive treatment in most cases, actually, and surgery is indicated for those patients when non-operative management fails or if they have specific indications. Studies have shown that return to sports at the prior performance level or higher is promising for patients who are appropriately treated, whether non-operatively or operatively. And lastly, hip injuries in young athletes, I think, can be treated comprehensively in the primary care setting. However, orthopedic referral is advised in select cases if there is any uncertainty of either diagnosis or treatment. Thank you.